Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen. Our webinar is about to begin. Before we start, please kindly keep your microphone off unless allowed by moderator. Thank you. First of all, I would like to greet our honorable guests, the Dean Faculty of Pharmacy Universitas Indonesia, Dr. Mahdi Jufri, Master of Science Apotheker, Vice Dean of Faculty of Pharmacy Universitas Indonesia for Academic Research and Student Affairs, Prof. Dr. Eri Yanuar, Master of Science Apotheker, Vice Dean of Faculty of Pharmacy Universitas Indonesia for Resource Venture and General Administration, Prof. Dr. Abdul Munim, Magister of Science Apotheker. Our speaker, Prof. Yasushi Fujio, MD, as the Dean of Graduate School of Pharmaceutical Science, Osaka University. Our moderators of today's webinar, Dr. Anton Bahtiar, Master of Biomedical Science Apotheker. Professors, fellow faculty members, and also all participants, welcome to the second International Guest Lecture Series Webinar 2021 that officially held by Faculty of Pharmacy Universitas Indonesia. My name is Rosa Murchayan Forestrania, a faculty member in the Faculty of Pharmacy Universitas Indonesia. It is very great opportunity for me to serve as Master Ceremony in this evening on our second International Guest Lecture Series Webinar 2021 entitled Cytokine Signaling in Heart Disease. This International Guest Lecture Series webinar is intended to broaden our knowledge for recent research development, to strengthen international collaboration between universities, and to experience cultural diversity and international insight-related research. This program comprises 3 series of guest lectures. This webinar is the second International Guest Lecture Series with the topic of cytokine signaling in heart disease, which will be delivered by our honorable speaker, Prof. Yasushi Fujio, MD. This program is sponsored by Academic Reputation Grant from the Directorate of Academic Development and Learning Research, Universitas Indonesia. Now, I will read the agenda for this webinar. The first agenda will be the opening by Master of Ceremony and followed by a photo shoot session. And second agenda will be a welcoming speech by Dr. Mahdi Jufri, Master of Science Apotheker as the Dean Faculty of Pharmacy Universitas Indonesia. And after that, we will move on to our main agenda, the lecture by our speaker, Prof. Yasushi Fujio, MD. And this session will be moderated by Dr. Anton Bahtiar, Magister Biomed Apotheker. This fourth agenda is discussion session with the speaker that will also be moderated by Dr. Anton. The last agenda is closing by Master of Ceremony. I hope everyone will be staying on this webinar until the end of the webinar. Ladies and gentlemen, now we are going to have a photo shoot session. For speaker, our organizing committee, and all participants of this webinar, would you please to turn on your camera and please the committee to guide this photo shoot session. Please give your best smile.
Excuse me, I can share the slides.
Oh, the lecture session will begin after the welcoming speech by the Dean of our faculty, Prof. Yeah, okay. I think the picture already taken by the computer, right? So I can move on to our next session. Okay. Okay, the next agenda will be a welcoming speech from the Dean Faculty of Pharmacy Universitas Indonesia, Dr. Mahdi Jufri, Master of Science Apotheker. We welcome you.
Thank you, Ibu Rosamor. Assalamualaikum warahmatullahi wabarakatuh. And very good afternoon. Honorable to Professor Yasushi Fujio, MD, the Dean of Graduate School of Pharmaceutical Science, Osaka University. Honorable to Vice Dean, Academic Research and Student Affairs, Professor Eri Yanuar, Vice Dean of Human Resources and Venture and General Organization, Professor Abdul Munim, all manager, all have our study program, all the pharmacy, all the preparation, lecturers and students. Also for the moderator this afternoon, Dr. Anton Bahtiar. This afternoon, we will hear a guest lecture about cytokine signaling in heart disease. We hope that with this guest lecture, we can continue in the future collaboration between Faculty of Pharmacy and School of Graduate of Pharmaceutical Science, Osaka University, about student exchange, staff exchange, and research collaboration. I will thanks to all committee which prepared this event running well. On behalf of Dean Faculty of Pharmacy UI, I officially open this webinar. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Thank you, Dr. Mahdi Jufri, for the welcoming speech. Before we continue to the next session, I would like to remind you to fill out attendance form that will be available in the chat box. Please keep your audio off during the webinar unless allowed by moderator. Thank you. Ladies and gentlemen, we are about to begin our main agenda, the lecture by Prof. Yasushi Fujio, MD, on the topics of cytokine signaling in heart disease. The session will be led by our moderator, Dr. Anton Bahtiar, MBA Apotheker. The discussion session will also be led by our moderator right after the lecture session. The participant may also ask questions directly to the speaker by clicking the icon raise hand under the reaction icon at the bottom right of the Zoom application. And when the discussion session is open, the moderator will invite you to deliver the question to the speaker. Or you may also type the question in the chat box during the webinar and moderator will read the question to the speaker for you. Before we start the session, allow me to briefly introduce our moderator, Dr. Anton Bahtiar, Master of Biomedical Science Apotheker. He obtained his undergraduate and master degree from Universitas Indonesia. He completed his doctoral degree in 2010 from Graduate School of Biological Science, Nara Institute of Science and Technology, Japan. And currently, Dr. Anton is a faculty member in Faculty of Pharmacy, Universitas Indonesia, and also serving as the head of Laboratory of Pharmacology, Toxicology, and the head of Pharmacist Professional Study Program at the Faculty of Pharmacy, Universitas Indonesia. Without any further ado, now please help me to welcome our moderator, Dr. Anton Bahtiar.
Okay, thank you, Dr. Nia, for the introduction of mine. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Dean and Vice Dean, Board of Professor, Board of Faculty Senate, and all audience. Today we are pleased to welcome Prof. Yasushi Fujio, a very special guest lecturer from Osaka University, Japan. Before we start, I will introduce him through his curriculum vitae. Professor Yasushi Fujio, born on October 14, 1962. Now he is professor at Laboratory of Clinical Science and Biomedicine, Graduate School of Pharmaceutical Science, Osaka University. He got medical doctor on undergraduate course of Faculty of Medicine, Osaka University on 1987, and PhD at a postgraduate course of Graduate School of Medicine, Osaka University on 1994. As professional, he started from a medical intern at Osaka University Medical Hospital on 1991 to 92, and as physician at Division of Cardiology, Osaka Medical Center for Cancer and Cardiovascular Disease, 1992 to 94, and as research resident at Graduate School of Medicine, Osaka University on 1995 to 97, and postdoctoral fellow at St. Elizabeth Medical Center in Boston, USA, and become associate professor on Graduate School of Pharmaceutical Science, Osaka University on 2002 to 2009, and became a full professor at Graduate School of Pharmaceutical Science, Osaka University from 2009 till now. He got a medical license from Ministry of Health, Labor and Welfare. He has qualification as a medical specialist from the Japanese Circulation Society on 2000, as a fellow from the Japanese Society of Internal Medicine on 2005, and a board-certified clinical pharmacologist from the Japanese Society of Clinical Pharmacology 2015. He became a few academic societies, such as the Japanese Society of Internal Medicine as counselor of Kinki branch, the Japanese Circulation Society as counselor of Kinki branch, the Japanese Society of Clinical Pharmacology and Therapeutic as a director, and as a delegate of the Japanese Pharmacological Society. He also has some awards such as Young Investigator Award from Scientific Conference for Cardiovascular Disease on 1997. As a finalist, Louis and Arnold Cass Research Prize from American Heart Association 1999, and annual award for education and research from Osaka University on 2006. As a medical doctor, he has two specialties in clinical field. There are cardiology and clinical pharmacology. Now he has three research topics: cytokine science in cardiovascular disease, tissue repair or regeneration in myocardial inflammation, and clinical pharmacology for precision medicine. Okay, Professor.
Thank you, Dr. Anton Batier.
Okay, the time is yours. Your present time is 45 minutes.
Yeah, okay.
Please.
I want to share the slides.
Okay, maybe the committee allow Professor Fujio to share his slide.
Okay. Is it okay? Can you see the slides?
Okay, Professor, okay. I can see the slide.
Thank you, Dr. Anton Batier. It's my pleasure to give a talk from Osaka University to University of Indonesia. Today, I'd like to talk about cytokine signaling in heart diseases. Before that, I will talk about the history of Osaka University using several slides. This slide shows the Tekijuku, the origin of Osaka University. Juku means a private school. Tekijuku was established in 1838. A number of graduates from Tekijuku contributed to the establishment of Japan as a developed country. Just 90 years ago, Osaka Medical College, originated from Tekijuku, merged with Shiomi Research Center of Science and became Osaka Imperial University. After World War II, the name was changed from Osaka Imperial University to Osaka University. This is the main gate of the campus of Osaka University, and this is University Hospital. Anyway, do you know where Osaka is in Japan? Osaka is localized around the center of Japan here. 2 years ago, a lecturer of University of Indonesia came to my laboratory. She is Trivopovni. We usually call her Uni. She is a hard worker. She has been studying about cardiomyocyte hypertrophy since she joined our laboratory. Thanks to Dr. Anton Batier's great education and training, she is an excellent scientist. So far, we discovered that myosin-1, a lipid mediator, induces a hypertrophy in cardiomyocytes. Our findings propose that a lipid mediator produced from macrophages regulates myocardial homeostasis for the first time. But in this lecture, I don't talk about her work. I talk about my work. In this lecture, I'm going to talk about the cytokines, especially IL-6 family cytokines in heart diseases. IL-6 cytokine family consists of several kinds of cytokines, including interleukin-6, IL-6, leukemia inhibiting factor, cardioprotective 1, oncostatin M, and etc. I will explain these slides later more in detail. Anyway, IL-6 family cytokine has been thought to be biomarkers of heart failure. This slide shows the relation between cytokine concentration of IL-6 and leukemia inhibiting factor with the severity of heart failure. As shown, the plasma concentration of IL-6 and LIF increase in the patient with severe heart failure, like this. Interestingly, some cytokine receptors are expressed in cardiomyocyte. Therefore, our question is, what roles IL-6 family cytokines play in cardiovascular diseases? By using the previous slide, I'll explain the receptor system of IL-6 family cytokines. As mentioned, IL-6 cytokine family consists of several cytokines. Each cytokine binds to its specific receptor. For example, IL-6 binds to IL-6 receptor, LIF binds to LIF receptor. Next, cytokine and its specific receptor complex binds to common receptor subunit, glycoprotein 130, GP130, and transducer signals in the target cells. The distribution of specific receptor expression explains the pleiotropy of the cytokines. For example, LIF receptor is expressed in cardiomyocyte, but IL-6 receptor is not. Thus, LIF can transduce its signal into cardiomyocyte, but not IL-6. The common utilization of GP130 explains the redundancy of the cytokine families. For example, both IL-6 and LIF receptor and oncostatin M receptor are expressed in cardiomyocytes. Therefore, these cytokines activate GP130 in cardiomyocyte and transduce similar signals in cardiomyocyte. Sorry. Today, I'd like to talk about two topics. One is IL-6 family cytokines ischemic heart disease, and second is IL-6 family cytokines and myocarditis. In the former half, I will introduce our translation research, and in the latter half, I will talk about involvement of cytokine signaling in cardiac repair and regeneration. First, I'm going. Sorry. First of all, I'll describe the signaling pathway downstream of GP130. Following the activation of GP130, three signaling pathways are activated: STAT, ARC, and ACT. Among these three signaling pathways, STAT pathway is the most important. In cardiomyocyte, STAT1 and 3 are activated in response to IL-6 family cytokines. The activated STAT3, phosphorylated STAT3, translocate into nuclei and activates the transcription of target genes. To make clear the biological significance of IL-6 family cytokines in heart diseases, we have been exploring the target genes of STAT proteins. This slide shows our findings from 1996. In response to extracellular stresses, cardiomyocyte produce IL-6 family cytokine. These cytokines activate three signaling pathways as described: STAT, ARC, and ACT. STAT pathway is most important, and the STAT pathway upregulate anti-apoptotic protein like BCL-XL, those scavengers manganese SOS, or metallothioneins. These proteins exhibit cytoprotective effects. In addition to these cell-autonomous pathways, STAT protein induces VEGF, an angiogenic factor, and regulate vascular function around cardiomyocyte as a non-autonomous pathway, and contribute to the maintenance of cardiac homeostasis. Interestingly, IL-6 family cytokines activate STAT3 in cardiac stem cells, for example, cardiac SCA1 cells, and induce transdifferentiation from cardiac stem cells to endothelial cells. These findings suggest that IL-6 family cytokines could protect cardiomyocyte from myocardial injury in cardiovascular disease. To examine whether STAT3 activation in cardiomyocytes results in cardiac protection, we generated cardiomyocyte-specific transgenic mice expressing constitutively active STAT3. Constitutively active STAT3 has the amino acid mutations, and as a result, in transgenic mice, STAT3 is constitutively activated even in the absence of IL-6 family cytokines. By using transgenic mice, we generated ischemia reperfusion injury. In this slide, white region is infarct area. As shown, infarct area is dramatically reduced in transgenic mice compared with non-transgenic mice. Based on these results, we tried to activate STAT3 in cardiomyocyte by using IL-6 family cytokines and protect myocardium from cardiac injury as a cytokine therapy. The problem is which cytokine is the most suitable for this purpose. The requirement of the ideal cytokine for this purpose is first, the specific receptor is expressed in cardiomyocyte because the cytokine must transduce its signals into cardiomyocyte. Second, the specific receptor is not expressed in inflammatory cells. In other words, the cytokine must not induce severe inflammation in human. Considering the second point, we focused on IL-11 because IL-11 was clinically used for the patient with thrombocytopenia. IL-11 is a thrombopoietic growth factor. The problem was whether this one, IL-11 receptor is expressed in cardiomyocyte. So we prepared cardiomyocyte and RT-PCR performed. IL-11 receptor messenger RNA was highly expressed cardiomyocyte. Consistently, the stimulation of cardiomyocyte with IL-11 activated STAT3, as shown this one. These data indicate that IL-11 receptor expressed in cardiomyocyte is functional. So first, we analyze cardioprotective effect of IL-11 by using preconditioning model. After IL-11 was intravenously administered, the heart were exposed to ischemia, followed by reperfusion. The bright portion was exposed in the myocardium, exposed to ischemia reperfusion. And the white portion, as I demonstrated before, was infarct area. As shown in this slide, infarct area was reduced by pretreatment with IL-11. Next, we examine the antifibrotic effect of IL-11 after myocardial infarction. In acute myocardial infarction, ischemia or ischemia reperfusion induces cardiomyocyte loss at acute phase. Importantly, cardiomyocyte deaths continue to occur at the border zone between infarct and intact area at chronic phase, and as a result, cardiofibrosis area expands, resulting in heart failure. To examine antifibrotic effect of IL-11, IL-11 was intravenously administered 5 consecutive days after coronary ligation. At day 14, the fibrosis was analyzed by Mason trichrome staining. As shown in slide, the portion stained blue staining was fibrosis area. As shown in slide, IL-11 treatment reduced fibrotic area in a dose-dependent manner like this. Mechanistically, we can propose 2 molecular mechanisms of antifibrotic effect of IL-11. First, IL-11 prevents the apoptosis after myocardial infarction. As shown in the left panel, tunnel-positive cells were decreased in number by IL-11 treatment. Second, immunofluorescent immunohistochemical staining revealed that IL-11 preserves the capillary density in the dose-dependent manner like this, indicating that IL-11 promotes angiogenic activity. To address the importance of STAT3 activation in cardiomyocyte, we generated cardiomyocyte-specific STAT3 knockout mice. As shown in wild-type mice, IL-11 suppressed cardiac fibrosis like this after coronary ligation. However, in STAT3 condition knockout mice, IL-11 failed to reduce the fibrosis like that. More importantly, STAT3 gene aberration deteriorate cardiac fibrosis compared like these two, like this. These data indicate that STAT3 protects myocardium from fibrosis intrinsically like this, even without IL-11, endogenous protective mechanism, I think. As more clinically relevant model, we used post-conditioning model. In this model, heart were exposed to ischemia. Just before reperfusion, IL-11 was administered, and 24 hours later, we evaluated the infarct area. As shown, infarct area was reduced in a dose-dependent manner in wild-type mice. Importantly, STAT3 gene aberration abrogated IL-11-mediated protection of myocardium. 20 microgram per kilogram is almost same with the clinical dose of IL-11 as a drug against thrombocytopenia. Therefore, we further went to first inpatient study. In this study, we administered IL-11 just before starting PCI, catheter therapy, in the patient with AMI. We enrolled 4 AMI patients with responsible lesion at LAD. CKmax showed the acute myocardial injury. The endpoint is cardiac function at chronic phase. Therefore, to evaluate the effects of IL-11 myocardial rescue, we analyzed the relation between CKmax and LVEF at chronic phase. This slide demonstrates the relationship between CKmax and LVEF at chronic time point 6 months later after PCI. Closed square shows a patient treated with IL-11. Open squares are the patient not treated with IL-11, historical control. The dotted line represents the average of the data of historical control. As shown, the treatment of IL-11 has tendency to improve LVEF at chronic time because these points are above the line. Unfortunately, the pharmaceutical company stopped producing IL-11. However, so I could not go further. However, we propose that activation of STAT3 in cardiomyocyte could be a promising strategy in the patient with AMI. Next, I talk about IL-6 family cytokines and myocarditis. This slide shows a pathogenesis model of myocarditis from New England Journal of Medicine paper. Viruses or toxic agents induce myocardial injury, leading to the exposure of intracellular antigen, such as myosin heavy chain, and evoke innate immune responses. After that, acquired immune responses is activated by T cells, B cells, and so on, resulting in severe inflammation. Finally, some patients recover from cardiac dysfunction when pathogen is cleared. However, some patients show persistent cardiomyopathy, like when the pathogen is not cleared. According to the recent circulation research review article, about 3/4 of the patients with myocarditis show cardiac dysfunction, like this. And in 80% of them, cardiac function recovers or improves. In this study, I focused on the molecular and cellular dynamics of myocardial recovery from myocarditis. In this series of studies, we used experimental autoimmune myocarditis model, EAM model. EAM is induced by immunization with myosin heavy chain peptide twice in male biopsy mice. 3 weeks after the first immunization, the inflammatory cells infiltrate in myocardium maximally, and the cardiomyocyte were damaged and shrink. Previously, we reported that EAM is a Th17 disease. We prepared CD4 positive cells from inflamed myocardium and performed FACS analysis. In addition to Th1 cells that express interferon gamma, IL-17 producing T cells, Th17 cells infiltrated into EAM myocardium. In Th17 differentiation, IL-6 induces low gamma T, a key transcriptional factor of Th17, in the presence of TGF-beta through STAT3. Therefore, blockade of transdifferentiation from naive T cells to Th17 cells by inhibiting IL-6 signaling pathways prevents the onset of EAM. Even without this intervention, after the peak of inflammation at 3 weeks, inflammatory reaction is spontaneously resolved in these models. Interestingly, damaged myocardial tissues also heals with improved cardiac function. Morphologically, Shrinked cardiomyocytes recover and show rod shape at 7 weeks. Damaged cell adhesion is also reconstituted in the process of tissue repair. To analyze the healing process of myocarditis, we examine the morphological changes of cardiomyocyte by immunofluorescent microscopy. In normal heart, cardiomyocytes have rod shape. Cardiomyocyte form cell adhesion with adjacent cells. However, at 3 weeks, cell adhesion was disrupted. Interestingly, cell membrane protrusion, which are possibly stained with anti-vinculin antibody, were observed at 3 weeks, indicating that structural remodeling occurs in cardiomyocyte. Finally, at 7 weeks, cardiomyocyte restore rod shape and cell adhesion recovers. Since acting cytokine remodeling with protrusions formation is essential for heart regeneration, cardiomyocytes at EM 3 weeks are likely to have regenerative properties. To address the molecular mechanism of cell structure remodeling, we analyzed protein expression profile. We prepared cardiomyocyte from control and EM 3 weeks heart and performed protein mix analysis. This table shows the protein that increased in EM cardiomyocyte. As shown, the expression of cytoskeletal and or structure proteins, especially myosin and XIRP2 is upregulated, suggesting that cytoskeletal remodeling plays important roles in myocardial healing. For example, it was reported that this protein, homolog, initiates the maturation of intercalary discs during neonatal, postnatal heart development. This is reminiscent of our finding that cell adhesion recovers from 3 weeks to 7 weeks in EAM. As for myosin, biological functions of myosin remains to be addressed in cardiomyocyte. We prepared cardiomyocyte from control and EM hearts and examined the expression level of activated, phosphorylated, and total myosin. Both activated and total myosin increased in cardiomyocyte from EM hearts. Next, we examined the localization of myosin by immunofluorescent microscopy. Interestingly, myosin was localized at the protrusion structure at EM 3 weeks, suggesting that myosin is involved in cell structural remodeling. We examined the effect of myosin overexpression on cardiomyocyte morphology by generating adenovirus vector expressing wild type, constitutively active type, and inactive type of myosin. Rat neonatal cardiomyocytes were transfected with these adenovirus vectors and stained with anti-sarcomeric alpha-actinin antibody. As shown, the overexpression of wild type and constitutively active type of myosin induces protrusion structure, while not inactive type of myosin expression. Summary: myocardial recovery from myocarditis has been believed to result simply from regulation of inflammatory cells. However, cardiomyocyte exhibit a structural plasticity during the healing process of myocarditis. So the healing process is active process, not passive, not simply regulation of inflammatory cell or tissue edema. Next, we focused on cardiomyocyte density. As shown in the upper panel, cardiomyocyte density is transiently reduced at EM 3 weeks and recovers at EM 5 weeks. At 3 weeks, tunnel-positive cardiomyocyte are observed, indicating that myocarditis induces cardiomyocyte loss. Though mammalian cardiomyocytes largely exit from cell cycle immediately after birth, we addressed the possibility of cardiomyocyte proliferation by checking the expression of cell cycle markers. Heart sections from control and EM hearts were stained with anti-Ki67, anti-Aura B antibodies. BRD uptake assay was also performed. As a result, unexpectedly, though the population is small, cardiomyocytes positively stained with cell cycle markers were observed at EM 3 weeks. To make clear the origin of the cardiomyocyte with cell cycle activities, the fate mapping study was performed after generating indicator mice. Because by this method, about 90% of cardiomyocytes were labeled with YFP. At EM 3 weeks, heart sections were stained with antibodies against cell cycle markers and anti-myosin heavy chain or YFP antibody. And there are no significant difference in the frequency of cell cycle marker positive cells between cardiomyocyte at EM 3 weeks, indicated by myosin heavy chain positive cells, and pre-existing cardiomyocyte, indicating YFP positive cells. Therefore, it is likely that cell cycle marker positive cardiomyocyte originated from pre-existing cardiomyocytes, not from non-cardiomyocytes, such as cardiac stem cells. As shown in the previous slide, EAM is Th17 disease, and STAT3 mediated transdifferentiation from naive T cells to Th17 cells is essential for the onset of EAM. Interestingly, immunofluorescent microscopic analysis with anti-hoso-STAT3 activated STAT3 antibody demonstrated that STAT3 activation is observed not only infiltrating cells indicated by arrowhead, but also in cardiomyocyte indicated by arrows at EM 3 weeks. Consistently, the expression of IL-6 family cytokine that were upstream signals of STAT3 is upregulated like this. Previously, it was reported that STAT3 is essential for zebrafish heart regeneration. So we examined the effect of myocardial STAT3 activation on cardiac repair in adult mammalian heart. In zebrafish, cardiomyocyte continue to have regenerative, proliferative activity even in the adult, while mammalian heart cardiomyocyte has only little proliferative activity. So and for a long time, it has been believed that mammalian cardiomyocyte cannot proliferate in the adult time point. But in myocarditis, we discovered cardiomyocyte can proliferate even in adult. So I wonder the common pathway functions in these processes. So we generated STAT3 conditional STAT3 knockout mice again. At EM 5 weeks, when inflammation was terminated, STAT3 CKO hearts were enlarged like this. Heart weight per body weight are increased. Cardiac function was impaired in STAT3 CKO mice, analyzed by echocardiography. Cardiac fibrosis was more obviously observed in CKO hearts, and number of cardiomyocytes were reduced like this. Therefore, in STAT3 CKO hearts, CKO mice, heart failure occurred after EAM. Mechanistically, the frequency of tunnel positive cells increased in STAT3 CKO heart at 3 weeks, and cell cycle marker positive cardiomyocyte decreased in CKO hearts. Summary slide. Pre-existing cardiomyocyte exhibit cell cycle activity in healing process of EM. As is the case with zebrafish model, STAT3 activity contributes to myocardial repair regeneration by increasing proliferative cardiomyocyte and by inhibiting cell death in EAM. Adult murine cardiomyocyte exhibit reparative regenerative capacities in response to myocarditis, contributing to the recovery from myocardial injury. Interventional activation of these capacities could be a novel strategy against heart failure. Thank you very much for your kind attention.
Okay, thank you very much, Professor Fujio. The nice presentation. Only 30 minutes, I think, your time. So I give the floor to ask some question about this lecture to Professor Fujio. You can raise your hand. Not yet. Okay, maybe. Okay, Dr. Fadlina, you raise hand, so you can ask the question to Professor Fujio. Please, Dr. Fadlina.
Yes. Okay, thank you very much, Dr. Anton. And thank you for Fujio for your very nice presentation. Maybe for my question is about the interleukin myocardial infarction. We know trigger an inflammatory cascade, and interleukin is very close related to this response. That's why this cytokine becomes suitable marker for myocardial infarction and restratification in heart failure patient. And we know that elevated levels of interleukin-6 associated with increased risk of future myocardial infarction and included in cardiac remodeling. As you explained, is for interleukin-6 signaling, circulating level of the common receptor subunit GP130 interleukin-6 family cytokine, and one kind of this family is interleukin-11. So interleukin-11 has a cardioprotective effect.
Yes.
So it looks like have different pathogenic roles in this disease. So can we determine the exact state when this cytokine can improve the cardiac myocyte agent ischemia or give the cardioprotective effect to become heart failure? Okay,
your talk is interrupted. And your question is the difference between the IL-6 and IL-11?
sorry, for interleukin 6, because the
6.
interleukin 11 is one kind of the family for the interleukin 6, right? Yes. And we know in the myocardial infarction, the interleukin 6 appear to elevate, to increase.
No, I know.
Yeah.
It is not good.
Okay.
But IL-6 receptor is not expressed in cardiomyocyte. So the function is different. In IL-11 receptor is expressed in cardiomyocyte. So IL-11 exhibit cardioprotective effect. But IL-6 receptor is not, or if any, very at the lower level expressed in cardiomyocyte. So IL-6 cannot exhibit the protective effect. Probably IL-6 receptor is expressed in fibroblast or other inflammatory cells. So IL-6 show the bad effect through these cells. I think is this okay for your answer, your question?
Okay, so even the interleukin 11 is one of a family of interleukin 6, but the role is different. That's mean.
Yes, it's a family member of IL-6 family cytokines. But the receptor, the distribution of receptor expression determine the pleiotropy of the cytokines. I show the slides.
Okay.
So IL-6 receptor is not expressed in cardiomyocyte. So even and IL-6 is increased after myocardial infarction or myocardial injury, but elevated IL-6 does not show the effect in cardiomyocyte. But IL-6 show the biological effect in cardiac fibroblast because IL-6 receptor is expressed in cardiac fibroblast.
Yes.
It's okay.
Okay. Okay, I get it. Thank you.
If you have some question, please give me email. Okay.
Thank you, Prof. Wijo. Next, Dr. Aini, please ask your question.
Thank you very much. An interesting talk, Professor Yasushi Fujio. I would like to ask about myosin. Yeah, is it a membrane remodeling protein or just a linker between the cytoskeleton with the membrane?
Yes, it's a linker between cytoskeleton, actin cytoskeleton, and the membrane.
Oh, it's a linker.
Yes.
Okay.
And so, the linking is regulated by phosphorylation.
All right. Okay. And again, and also, do you also study about the membrane lipid composition that change during myocardial infarction? Do you also study about the membrane lipid composition?
No. I have no data.
Okay, that's all. Thank you very much for your answer.
Okay, thank you. Next question from the audience. Okay, Dr. Raditya, please ask your question.
Okay, thank you for the chance to Dr. Anton for the chance to speaking here, and thank you very much also to Prof. Yasushi Fujio for
Yes.
your presentations. It is such nice findings for your research, because beforehand I also have the research in the fibrosis, but in the intestines and also in the liver. And your findings is also quite nice, because there is the cytokines like interleukin 6 and interleukin 11 that you find that give such like the compromise. And beforehand, I found also, if I'm not mistaken, your research is did in the murine, right? It is the mice or rat?
Mice.
Mice. And do you have any research also in the human for these kinds of finding?
Mm-hmm.
Your research also did
I
in
have
human?
in human.
In human, yes.
Not
yet?
I demonstrate the first inpatient study.
Inpatient study.
Yeah,
And
it's human.
yeah. And do you find any correlations between the findings in murine and also in human?
Yes, I think
Yes.
because single administration of IL-11 rescues the myocardium like this.
Mm-hmm. Yeah, because beforehand from my research, there is no correlations between the human samples and also the murine. But in your research, it seems there is quite interesting, because there is the correlations between the humans and also the murine samples.
Yeah.
So that's good for the next experiments.
Thank you very
Professor.
much.
Yeah.
Okay, thank you, Dr. Raditya. Other audience? Any question from other audience? Okay, maybe from me, it's very interesting when you talk about STAT3. So in adult mammalian, the STAT3 is the expression is very low. From your experiment, STAT3 is low.
It's what?
STAT3
expression level.
Yes, expression level is
it's
low.
very high.
Oh, very high.
It's very high in heart.
In heart. Oh, okay.
And STAT3, excuse me, STAT3 is ubiquitously expressed. Ubiquitously in almost all the cells.
Yes, and you said if the STAT3 decrease, so apoptosis increase. So,
yes.
Do you have I saw from your slide you make knockout or overexpression of STAT3 in mice to see the effect?
Today I didn't talk about the transgenic mice.
Yes.
You mean the expression level?
Yes. No, the function when you express the overexpression, the STAT3.
Yes.
Do you have
this paper? This one?
Yes. Yes. Yes.
In this case, we use the constitutively active STAT3 because we don't have to administer IL-6 family cytokines into mice. By using this system, we can exclusively activate STAT3 in cardiomyocyte.
Okay. And what happened with the mice is
in this mice?
Yes.
In this mice, we found we got two findings. One is overexpression of STAT3 result in the resistance to ischemia reperfusion. Today I explained.
Okay.
And another finding is the capillary density was increased like this. This slide is from IL-11 treatment, but same findings are observed in this overexerted transgenic mice.
Okay, thank you. Another question from the audience? Okay, no question. Okay, maybe I back to your experiment about interleukin 11 on human. Do you have data about the adverse drug reaction? Adverse drug reaction when the human get interleukin 11? Any side effect of
side effect? In this case, we treated only once, single administration. So we cannot see the adverse events. When the people use the IL-11 as as a thrombotic growth factor, the IL-11 is administered for 2 weeks or 20 days. In that case, some adverse events are observed. But in my case, we just administered the IL-11 only once, just before reperfusion.
Okay, thank you. Is there anything, any question from the floor or audience? I think very interesting. You have 3 data. No more question? Maybe Dr. Fadlina still have questions.
Yeah, thank you, Dr. Anton. And I wonder about the patient study. Yeah, for this patient study, you give the interleukin. Yes, you give the interleukin 11 to the patient to against the acute myocardial infarction. So I want to know exactly when you give this interleukin, 1 or 2 or maybe 3 hours after the injury. I mean, after the acute myocardial infarction, or when exactly the time to intervention the patient.
Just after we found that the patient has a coronary occlusion at LAD by CAG, we start the administration by IL-11, and we administer the IL-11 for 2 hours.
2 hours. Yes. 2 hours after.
No, just before deciding to go to PCI.
Okay.
If possible, if we can administer IL-11 while transporting the patient to the hospital, the effect would be better, I believe.
Yes.
The earlier is better, I think.
Yeah.
Okay.
But that ethical problem prevent us to use such kind of clinical trial. Okay.
Okay. Thank you. Is there any question from the audience? No more question. Okay, Professor Fujio, thank you for your great explanation and also your presentation. Maybe I will give the time to the MC again, Dr. Nia.
Okay, thank you, Dr. Anton. Thank you very much, Prof. Yasushi Fujio, for the excellent and insightful talks. We are all getting excellent knowledge and your perspective about cytokine signaling, especially in heart disease. And I would also like to thank to Dr. Anton that had been moderated this session very well. Before we continue to the next session, I would like to remind all of you to fill out attendance list and our evaluation form for today's webinar in the chat box. Your feedback is very valuable to help us evaluating this webinar and allow us to make continual improvement on our event. The form will be available soon. Okay, I think the form is already available in the chat box. Next, we would like to award Professor Yasushi Fujio a certificate of appreciation for the excellent lecture. I would like to invite again Dr. Anton to virtually giving the certificate to our remarkable speaker. Dr. Anton, we welcome you.
Okay, thank you, Dr. Nia. Professor Fujio, thank you for your kindness to Uni and also to me. Always take care Uni until her graduation, and also in behalf of Dean of Faculty of Pharmacy and the committee. Actually, we have a certificate of presenter. So maybe the committee has the certificate or something. I give.
Yes. Please, the committee to share the e-certificate.
Okay.
Yes, please.
Maybe Professor Fujio, Dean of Pharmacy and the committee. Actually, we have a certificate of presenter. So maybe the committee have the certificate or something. I guess. Okay.
It is.
To share the e-certificate.
Yes, please.
Maybe Professor Fujio. Okay. This is this certificate appreciation.
So thank you very much
for you.
This one.
Okay, this one. So this from Dean of Faculty of Pharmacy and the committee. Okay. Okay.
It is.
Share the e-certificate.
Yes, please.
Maybe Professor Fujio. Okay. This is this certificate appreciation.
So thank you very much.
For you.
Okay, I think the voice is getting feedback. Maybe would you please turn off your audio so we can continue for the next session?
Committee. Okay.
It is.
Share the e-certificate.
Yes.
I'm sorry for the audio, Professor Fujio, but we all thanks to for your time. Give a lecture to us, very valuable. Thank you. Dr. Nia, please, the time for.
Okay, thank you. Yeah. Okay, thank you, Dr. Anton. Okay, before we close this webinar, I would like to inform you that we will have the third International Lecture Series webinar on this Saturday, May 1st, 2021, with the topic of microneedle by Professor Ryan Donnelly from Queen's University, Belfast, United Kingdom. Finally, we come to the end of this webinar. On behalf of the host and organizing committee, I would like to extend once again our deepest appreciation to all of you, the speaker, moderator, invited guests, and all participants for sparing your time to participating in this webinar today. I would also like to thank to all of the organizing committee for arranging this webinar very well. Once again, we would like to thank you. May you find this webinar useful and bersama channel for Strania. Sign off and see you in our next webinar. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. See you, Professor.
Thank you very much.
Thank you very much.
Thank you
so much, Professor.
Thank you.
You.
Okay, izin live ya. Makasih.
Ya, terima kasih Bu.
Ya.
Terima kasih Bu.